Welcome to the webinar, Responding to Strong Emotions. Hi, I'm Barbara Lewis. I'm the managing editor for .com, an online communication skills learning system for medical schools, residency, PA, and NP programs, and hospitals, now that .com offers over 40 CME credits. Joining me today is Dr. Tim Gilligan, an oncologist and vice chair for education at Cleveland Clinic's Taussig Cancer Institute. He is the co-author of .com Module 13, Responding to Strong Emotions. Welcome, Tim.
Thank you very much. It's a pleasure to be here. I'm looking forward to it. I spend a lot of my time teaching communication skills at the Cleveland Clinic and elsewhere, so I'm looking forward to addressing the subject today.
Great. So tell us a little bit about your background.
I'm a medical oncologist and have a strong background in education. I ran our training program in oncology for 9 years here, and now work at the Center for Excellence in Healthcare Communication at the Cleveland Clinic, where we've trained over 5,000 physicians in basic interview communication skills with patients. And how we deal with emotions has certainly been a big part of that teaching.
Yeah, I can't even imagine, especially in your line of work. I'm sure you're dealing with strong emotions every day.
Yes, cancer provokes a lot.
Yes, yeah. So the webinar is going to last about 30 minutes, and a recording and the PowerPoint will be available on the .com website within the next day or two. At the end of the webinar, I'm going to give you a code for a free 1-month trial subscription to .com. And if you have any questions, you can type them in the chat box that's located in the panel. And let's see, if we don't have a chance to get to your question during the webinar, we will respond afterwards. So let's get started. Tim?
So we're going to be talking obviously about strong emotions today. And one of the key ideas here is that when we're giving people news that changes their life, strong emotions are a normal response. If we give people bad news, we expect people to be sad. Yet oftentimes, the patient's experience in healthcare is that the people they're dealing with are not comfortable with strong emotion. And the one thing we're going to talk about today is what are strategies we can use to be more effective with our patients and for our own job satisfaction. Emotions can originate in the patient, or they may be triggered in the clinician. We're humans too. We have our own associations and responses. And it's not just an issue of paying attention to what's going on in the patient, but also an issue of what's going on inside ourselves, so that we're aware of why we're reacting the way we are and can control that in a helpful way to the patient. One of the key ideas here is that if we respond with empathy to strong emotion, we can help the patient, we can strengthen our alliance with them, and we can move into a more healing space with them. And we're going to talk a little bit today about how an empathic response is really different from trying to make the patient feel better or trying to reassure them or things like that. And we'll talk about why some of those impulses can at times be problematic. My experience, I think the experience of my colleagues here, is that if we learn to respond skillfully to emotions, it actually is beneficial to us as clinicians. It's a competency that's helpful to us as well as being helpful to the patient. I'm just waiting for the slide to advance. Give it a moment.
Can you change the slide? Okay, I'm going to give it back. I'm going to give it back to you. Let me see if that works. Go ahead. I think you should have control, Tim, now. Yes.
There we go. So empathy, this is a term that's used more and more now. You hear it thrown around. I don't always know that people have a shared understanding of what that word means. Empathy is really about imagining what someone else is going through. We can't necessarily feel someone else's feelings, but we can, in a sense, project ourselves into their situation. So in my world of cancer, I might ask myself, what would it be like to have a doctor tell me I had cancer, or that my cancer had come back, or that I had heart failure, or whatever. Expressions of empathy are a way to demonstrate that we care. So the goal with empathy is not to make the person feel better. We do want to make the person feel better, but the goal in expressing empathy is really to show the person that we are trying to imagine what they are going through, and that we appreciate what they're going through, and what they're going through has meaning to us, and that we recognize that it has meaning to them. So that, in other words, they're not invisible to us. We can see them and we can see their experience. There's biology behind this. People will sometimes say, well, you can't teach people to be empathic. And the good news is you don't have to teach people to be empathic. We are born with empathy. There's strong evidence of empathy, not only in humans, but also in primates. There are mirror neurons in the brain, and it's described on the slide here. But essentially, mirror neurons fire in response to seeing in someone else the same neurons that would fire if I experienced that myself. So the example I've given here is, if I see you smile, some of the same neurons in my brain fire that would fire if I smiled myself. And we have an emotional response to each other. In medical school and residency, our empathic capacity deteriorates. So there's something in medical training that seems to beat the empathy out of people. And in a sense, when we talk about empathy and training, we are trying to reawaken our native empathic capacity rather than trying to instill something that wasn't there in the first place. Where we often get stuck is not that we don't feel empathy, but we don't express it in a way that the other person can tell or can see it. So in terms of responding to emotions, one of the first steps is recognizing that emotion is present. So if we go into the room with a patient, one of the key things we can do rather than talk is to listen and watch and try to see what's going on, and to use our energy observing rather than projecting or transmitting in terms of speaking. If we can be aware of other people's emotions, look at them, try to see what they're going through, that's the first step to be able to express empathy. Because if we don't notice their emotion, we can't really respond to it. And if we don't make a point of watching and observing carefully, we often miss it. We need to develop a comfort level. When someone starts crying, most of us feel uncomfortable, and there's an impulse to do anything to get them to stop crying, and that impulse is not helpful to the person who's crying. I've seen physicians do this when I coach. I saw one doctor who was dealing with a child who was smiling in the middle of a minor. He was having his nose cauterized. It was bleeding, and the child had tears going down his face, and the doctor said to the patient, "Don't cry, smile." People can't do that. They can't just turn off their emotions like that. But we all often have an impulse to do that. If we can get comfortable being around people who are feeling strong emotions, we can be more helpful and we can respond in a more helpful way. But we have to get over that discomfort that leads us to try to shut down other people's emotions. And that's where reflexive responses can get us into trouble. We feel uncomfortable with the strong emotion, so we try to shut it down. We change the subject. We tell them it's going to be okay, even if maybe it's not. Often in medicine, we don't have a lot of reassurance. If I tell a patient they have advanced cancer, I can't tell them it's going to be okay. It's not necessarily going to be okay for them, even if it's tempting to say that, and to try to make them feel better in the moment. The empathic response is an alternative. Rather than trying to shut down the emotion, rather than trying to make them feel better or reassured, acknowledging that we can see that they're upset. Patients, hopefully, if we do this well, will then feel more cared for. And it can help stop the escalation. The analogy I use is that strong emotions are like abscesses. We have to unroof them. We have to let them drain. And we do that through empathic responses and through acknowledging it. If we pretend they're not there, the emotions tend to escalate. Patients make repeated attempts to let us see them. If we see them and acknowledge them, it makes it easier for the patient to move on sooner than they would otherwise. There's also our response. Emotions are contagious, partly because of our empathic response. When we see strong emotion, we respond emotionally ourselves. Becoming aware of how we respond to these strong emotions can be helpful. So if I know that I'm uncomfortable with anger, then I know that if I'm around someone who's angry, I'm at risk of responding in a way that's not geared towards helping the other person or not in a way that's effective. If I can be more personally aware of what pushes my buttons, I can then respond to them in a more thoughtful and measured way and not do things that I end up later regretting. But it's important to remember that strong emotions can provoke that in us, and we have to find ways to manage that. When patients become very sad, if we give them bad news, that can trigger sadness in us, and that's just a human response. One thing that can be helpful is to remain in a space of curiosity rather than judgment. If we think that there's some correct response or best response, or the way someone's responding is not appropriate, that can lead us down a path that's not helpful as well. And instead remaining curious as to how they're responding and why they're responding that way, and not stepping into a judgmental space can help. It was interesting when I spoke with this doctor who told the young boy to stop crying and to smile. We later debriefed, and I asked him what he thought was going on for him in that moment, and he said, that when he thought about it, what he realized is that when a patient responded in a way that seemed exaggerated to him and more than he thought was appropriate for what he was doing to them, it made him angry. And so in a sense, he had responded inappropriately because he was mad. If you are aware of that in yourself, then you are much more empowered to not respond that way and to control it and respond differently. And that's what is the hope here, is that a greater awareness of our own emotions can help us refrain from responses that are not helpful or not empathic. So how can we do better? Patients who feel understood are helped by that. I said before that we want the patient to feel seen or heard. We don't want them to feel like their suffering is invisible to us. But if we don't respond, if we don't see it, if we don't say something, if they look really sad and we don't comment on it, they may think we don't care or don't value their experiences, or again, they may just feel invisible to us and feel like we just don't get it, we don't understand it, which is a common complaint from patients using our healthcare system. Our empathic responses then can help us connect with them, help them feel seen, help them trust us, and can also help them then explore their stories of illness more efficiently. There's actually good data that visits that contain empathic statements are shorter than visits that don't. That if we express empathy, both surgical and non-surgical specialties, this has been shown, expressions of empathy can help us be more efficient. So we're going to spend some time now just talking about specific strong emotions and how we might respond to them, what triggers them, and how to manage them empathically. So intense sadness, it's really worth emphasizing that sadness is a normal response to bad news. If I tell someone that they have a serious illness, I can't expect that they're going to be happy leaving my office. That would be weird. If they cry or if they're sad, that's a normal response. So I need to be prepared for that. One of my competencies needs to be, I know how to be helpful in that situation, how to be present. And this sadness may be expressed in a variety of ways. They may not say that they're sad, obviously. They may not cry. They may just look sad. They may look away. Paying attention can help us figure it out. And if we don't know, we can ask what's going through your head. How are you feeling? Gentle exploration and curiosity are more helpful than, again, we've touched on this previously today, rather than trying to make them feel differently or trying to reassure them when we don't have reassurance to offer. If someone comes in and has appendicitis, I can reassure them that if we take out their appendix, everything's going to be okay. But oftentimes in medicine, we don't have that kind of reassurance to offer, and we can get into trouble if we move prematurely to reassurance rather than empathic responses acknowledging what they're feeling. However, we want this to be in response to what the patient needs. The purpose is not for me to demonstrate how empathic I am. It's not to throw empathy at every patient. It's trying to figure out what each individual patient needs and how to respond to that individual. So giving the patient some control over whether we're going to discuss it and how we're going to discuss it is important. If they don't want to talk about their emotion and they don't want to talk about how they're feeling, then for me to try to force them to is really not being in relationship to who they are and what they need. So there's a balance. Some patients need a lot of empathy, some don't. The important thing is to know how to express empathy effectively and how to talk about emotion effectively for the patients who want to do that and who find it helpful. But that's not going to be everyone. Again, watching, listening, curiosity, exploring can help us figure out who the individual is before us. And I actually think that's one of the hardest communication challenges in medicine, that our patients are so different and that what works well with one person is exactly the opposite of what someone else needs. And if we don't learn how to adapt to the individual, it's hard to consistently do a good job. So how do we respond to intense sadness? Naming the emotion can be very helpful. We don't know what else to say. You seem sad, you seem upset. Can you tell me what's upsetting you? Giving them permission to explore it. Again, if we get a signal they don't want to, we don't need to, but patients in general are grateful for an opportunity and permission. They may feel like they're not allowed to talk about this. By naming it and opening it up, we give them permission. Acknowledging statements can be helpful. I can see this has been really hard for you. We have another example written up here, but in a sense with acknowledging statements, what I'm trying to convey is that I get it, that being sick really sucks. Finding some way for the patient to hear that. And that could be very powerful. It can be very powerful for patients to hear their clinician acknowledge that they get that it has been really hard for them. We often fail to say that. Maybe we just assume everyone knows it. Respect can be helpful. I'm impressed with how well you've coped with such a devastating loss, giving them some kudos for what they have done to hold it together. And then supporting and partnering statements. I think partnering is really very powerful in the sense trying to make the patient feel that I'm on their side and I want to help them, and finding some way to say that out loud. It may seem gratuitous, but I don't think it lands in a gratuitous way on patients. Something along the lines of what we've written here: I'm concerned about you and I want to help you feel better. I'm hoping we can work together. Getting that stuff into words out loud that the patient can hear rather than just assuming that they know it is important. What about fear? A lot of scary things happen in healthcare, and when we're sick, it can be scary. We can help patients by bringing their fears out into the open, letting them know that it's safe to talk about it, that we're willing to listen to it. Again, resisting false reassurance out of an effort to minimize the patient's or our own discomfort. But things become less scary when they get out in the open and when they're talked about in general. So here are some tools we can use. You seem apprehensive. Exploring what worries you most about this illness, what worries you about end of life or dying, what worries you about surgery. Getting them to talk about it out loud, naming it can help them start to get some control over it. And then validating and providing support. Maybe pastoral services or counseling will be helpful. Maybe just naming the fear and hearing that it's not surprising. Most of my patients feel this way, for example. And because a lack of control is one of the scarier parts of being sick, it's certainly true for cancer, I think it's true for a lot of illnesses, then any positive action they can take can give them a sense of control. Here's something that they can do, can be helpful for them in that situation. Not that we can make everything better, but sometimes there are things that can be done. So for instance, parents of children who have a terminal illness, if the parent has a terminal illness, we may not be able to save their life, but there are things that parents can do that are meaningful to them, such as making video recordings that their children will be able to play later on when they reach certain milestones in their lives or things like that. Many patients have told us that they find things like that very meaningful, but they may not think of doing it on their own. Responding to intense fear, again, legitimization or validation. Just getting it out there that what the patient is going through is not surprising. That it's a normal human response. People who are suffering often feel that helpful because we are in a culture that's often uncomfortable with strong emotions. And when we feel strong emotions, we may feel that that's a sign of weakness or some inadequacy in of ourselves. Normalizing it for them, saying, it's not surprising you feel that way. Most people in your situation feel that way. We hear from patients that that is helpful. Again, acknowledging statements, you're dealing with a lot right now, respect, and you're doing very well with it. Partnering, I want to work with you to help you get through this. All of these kinds of things, again, are empathic statements that can be helpful. What about anger? I think this is actually the one that's hardest for a lot of us. It can feel like we're being attacked, and it can be hard to resist the impulse to try to defend ourselves. So why do people get angry? Here's one formulation of it: reacting to an injury or loss or potential loss by fighting back against the threat. And sometimes what we get is anger in place of sadness because some people feel more comfortable expressing anger than expressing sadness. Sadness shows vulnerability. Anger is a more aggressive stance, and it may feel less vulnerable to people. So sadness or depression can come out as anger. And it can be difficult for some people to acknowledge it. There's the sort of stereotypical funny example of you say, why are you so angry? And the person screams, I'm not angry. It can be hard for people to acknowledge it even when it's obvious that's what they're feeling. And so finding a way to talk about it is important. So how do we respond to it? Naming the emotion again. You seem angry. Help me understand. If someone's angry and we don't acknowledge it, what most typically happens is they get more angry. If we get them talking about being angry, it helps that anger peak and start to diminish over time. We can legitimize it. Anyone would be upset. Partner with them. I hear what you're saying about how much pain you're in, and I want to help you feel better. I'm committed to working with you to develop a plan for managing your pain. I'm on your side. We have common ground. I'm not your opponent. One of the great things about medicine is we are on the same side. We want the patient to get better. We want the patient to feel better. We're not in court with the prosecutor and the defense attorney. We're actually trying to row in the same direction. And if we can help the patient feel that and trust that and believe it, it can help navigate through these difficult moments. But what about when it's really out of control? Our own safety is important, and it takes precedence over being therapeutic. So we put some guidelines here of what to do when you have someone who is losing control because of their emotion. So one thing is to set some boundaries. So we have an example here in the quotation on the left. I'm willing to continue this conversation as long as you exhibit the same respect towards me that I'm giving you, because it's reasonable and appropriate and fair for us to expect to be treated respectfully and for there not to be threats against us and things like that. Hopefully this helps the patient de-escalate. If it doesn't, then we may need to set limits more firmly. If you continue to disrupt our ability to conduct care safely in this clinic, I'll need to call security. And that's entirely valid. I think in order for us to feel comfortable with strong emotion, we need to know where the limits are, and we need to know when to protect ourselves. And when we feel unsafe, then it is entirely valid to protect ourselves. We're not expected to get abused or being taken advantage of. So here's a tool that I want to talk about briefly as we get towards the end of this, which is PEARLS. It's a mnemonic for how to express empathy. And these are 6 things that we can do. The first and the 6 are very similar, so you could say it's 5 things. But there's 5 or 6 things that you can do specifically to show the patient empathy. So one is partnering statements. We've shown examples of those. Naming the emotion. Appreciation statements for I get it that this sucks, that you're suffering, that this has been hard for you. Respect statements, honoring what they've done, how hard they've worked to quit smoking or lose weight or show up for all their appointments or whatever, honoring the work that they have done for their own health. Legitimizing statements. Most of my patients feel this way, things like that. And then supporting statements that I want you to get better. I'm going to help you. You're not in this alone. Those are things we can do specifically. So when in doubt, there's strong emotion present. We're feeling anxious because there's strong emotion present, and we may not feel entirely comfortable with it. These are things we can do that are more helpful than jumping in with premature reassurance or trying to shut down the emotion or changing the subject. So in conclusion, our goals here are to maintain a professional demeanor in the presence of strong emotion and not be uncomfortable with it, or to manage our own discomfort professionally if we are uncomfortable with it, and not react reflexively in a way that's not helpful to the patient. To use empathy skills using the PEARLS, calibrating our response to emotion appropriately, remembering to explore where this is coming from. So if a patient is emotional, not shutting it down or the conversation before we really understand what's going on. So again, exploration, curiosity, trying to understand what the patient's going through so that we can empathize with them more effectively. And lastly, learning to be aware of our own emotions and our own emotional responses. So that's the material I wanted to cover. I'm going to turn it back over to Barbara, and there may be some questions to discuss at this point.
Yes, there is a question. Thank you. We have a question. Do you think empathy is inherent or instinctive in a caregiver? And can empathy be taught?
So I think that we have inherent capacities for empathy. I think people respond when they see emotion. I mean, you think of like, when we go to the movies and we cry over something sad happening, in a sense, that's an emotional response. Nothing sad has happened to us. We haven't lost anything, but the suffering that we see, we feel it sometimes at a very visceral level. We have the capacity to do that, but sometimes that gets trained out of us, and we need to relearn how to do that.
That was actually the next question, Tim. It was, is empathy outbred in the medical education process? And do you have any ideas of what we can do about it?
It's a great question. So I think normalizing it and stopping the practices that shut it down are important. By teaching it and letting people practice it, I think in some ways, I really view communication skills as motor skills, not cognitive skills, and we get better at them by practicing them, by getting feedback. And with medical students, with residents, I feel like we've had a lot of success having them practice empathy and normalizing it. I think of a story. There was a lovely column in the New York Times a couple of years ago from a pediatrician who talked about being in the room with 2 parents who had lost a child, and one of the parents was crying, and this woman was an intern, and she started crying, and she later got yelled at by her resident that it was unprofessional to cry in front of patients. And so I think we need to stop that kind of behavior, that her response was a normal human response. And she actually talked in the essay about later on, when she was more senior, being with parents who had lost a child, it's still in pediatrics, and this happens. And the father started crying and apologized for crying. And she said she had this moment of horror that she had become someone that someone would apologize for such a normal response. As a parent, we expect someone to cry if they lose a child, and yet here was someone apologizing for doing that. And she worried about the message the healthcare was sending to patients. And so I think if we change the culture, that helps. And I think if we practice our skills, that helps.
Oh, we have questions coming in, so let me continue here. You mentioned data showing that visits containing empathic responses are shorter than those that don't. Where can we find more information on that research?
So we have specific references, and I don't have them at my fingertips, but I have them on my computer. And I think we have email addresses, right, Barbara? So we can.
Yes.
There are a couple of papers.
So yes, I can send those out.
One is looking at surgical visits, and one is looking at medical visits. Both showed that visits were longer if empathic statements were present.
Some healthcare.
Shorter.
Sorry.
The visits were shorter when empathic.
Shorter, yes. Some healthcare professionals feel you should never use the word I in an empathic statement unless you experience the exact same medical issue. Is it appropriate to say, for example, I understand this is very upsetting for you?
That's a great question. So I want to separate it. I would never say I understand if what I'm conveying is I understand what you're going through, because I don't understand what anybody else is going through. Only they understand it. I can try to understand it. So I might say I can only imagine what you're going through. But I like the use of the first person. I like personalizing it. I think it's a way of showing that I actually have an investment in your outcome and it matters to me. So for instance, my patients who have cancer who are smoking, I might say, I would hate to see you come back here with lung cancer because you were smoking. I think that's much more effective than saying smoking can cause lung cancer. You don't want to get lung cancer, do you? I like to personalize it, but I think using the word understand is very dangerous. It can be very dangerous. And I think of my own experience. I once told a veteran with chronic pain, he was telling me how bad his pain was, and I made the mistake of saying, I understand, and I got a 5-minute lecture on how I couldn't possibly understand. I think it's a dangerous word to say I understand, but we can show them that we are trying to understand and we are trying to imagine, but it's important not to be presumptuous that we know what it's like. If a parent, like my other example, has lost a child, I don't know what that feels like. I hope never to know what that feels like. I can't say to them, I know what you're going through, and we have to be careful about that.
Mm-hmm. Mm-hmm. So why do you think that those mirror neurons diminish during medical school?
So I don't know that the mirror neurons do. I know that the behavior does, or there are multiple studies showing that measures of empathy decline during training. So people are put under a lot of stress. They don't get enough sleep. They're treated abusively. And when that happens, we become less caring. I think one of the major problems I find when I am on call all night and have to go to work the next day without adequate sleep, it is harder for me to empathize with my patients when I am not feeling well myself, when I barely have any energy. And the kind of grueling process we put residents through, I actually am someone who believes there are benefits from that. I learned a lot from my nights on call as a resident and intern, and I have mixed feelings about hour regulations. I'm not talking about that, but when we don't feel like we're being cared for ourselves, it's hard for us to care for other people. And in medicine, I think it's gotten a lot better, I really do, but in the history of medicine, we used to train people somewhat abusively, with a lot of hierarchy and a lot of humiliation, and that is not a great way to reinforce people's empathic capacity.
So we have 1 minute left, and I just wanted to go through a couple more slides because I wanted to also give you a code so you can look at this module actually. So you can get more information from Tim's .com module number 13, Responding to Strong Emotions. And of course, I'm sure you're all familiar with evidence-based importance of communication skills that improve medical outcomes, decrease malpractice claims, enhance satisfaction. And now with HCAP surveys, we're finding that the communication dimensions, the 2 dimensions in the HCAP surveys, which are around communication, are actually driving the scores. And Cleveland Clinic was one of the first to come up with that analysis, actually several years ago. So let me just tell you very briefly about .com. We have 42 modules, each about an hour in length, over 400 videos. We have lots of interactive videos, annotated, and lots of faculty resources. All of our modules have a consistent format. These videos are really appreciated by the learners. We go through, we annotate them. This one happens to be on delivering bad news. You see it highlighted what we're talking about, and then if you click on the camera icon, the physician pops out and tells what's going on in the back of his head. Here's one on empathy understanding, which you may want to check out. This is to test your understanding of empathy, which is a fantastic video. One on facial recognition, and plenty of resources too. So Tim, thank you so much for this critical information in dealing with strong emotions. As I'm listening to this, I'm realizing it's not just about patients. It's really everybody that we deal with who has strong emotions. These are all really good techniques to handle strong emotions. And thank you to everyone who joined us today. The recording and the PowerPoint will be on our website shortly, and we'll be answering your questions if you have any others. At the end of this, there'll be a very quick survey for you. I would be most appreciative if you would fill it out and let you know what you think, and also if you have any ideas for upcoming webinars. We're going to be starting podcasts soon as well, and hopefully you'll sign up for those. Tim, once again, thank you so much. This was absolutely fantastic today. I'm sure everyone learned a lot. You could tell by the questions. Thank you.